they measured the left atrial, right atrial pressures, and the transesophageal studies found no difference in the embolic phenomenon, provided you are using a modern cementing technique. The question is, we are not using that. That's why we are getting complications. We are not using vacuum mix, neither are we doing vacuum drainage. I heard this term first time while preparing for the talk. Now in this vacuum drainage, we all put a suction inside the femur when we are inserting the cement. And I hope everyone agrees. We all put a small suction tape or a fan feeding tube, and then as the cement goes in, we pull the fan feeding tube out. That's just one bit. Apart from that, Pitt, the famous paper which he has written, he has said that in the proximal part of the femur, on the posterior side, make another hole and put a metal suction tip. And this two tips is called vacuum drainage of the femur, and there has been no results showing that the embolic phenomenon is there.
I agree with you. It is not that common, this particular common, but it is there.
It is there. It is there, provided we are not using.
As far as the papers you quoted, really great. You have gone through and have picked up some papers, but I am talking about an average expert. I am not talking about experts who are very good in cementing. They will not have any problems. They will get same results like an uncemented hip. But I am talking about an average surgeon who may not be that good in cementing technique. Any technique should be safe in the average hands. Then only that becomes very popular. Not in a select group of people who can deliver excellent results.
Right.
So my contention is that one. So in that way, even if it is a remote possibility, I think it needs to be taken into consideration.
So for the purpose of debate, I will agree to disagree with him. So to make it more interesting. So you said, sir, that cementing is more challenging than the uncemented hips. And I feel it is just the other way around. Because how many times you have tried to do an uncemented hip and ended up by doing a wrong reaming of the acetabulum, and what has bailed you out? A cemented cup. A cemented step. How many times? Many times. You have not got a good leg length, you pull the cemented stem out. You haven't got a good offset, you pull it out or change the offset angle. Cementing, yes, proper cementing, not with the finger mixing, using a cement gun, using a vacuum mix, using a pressurizer, cleaning the femoral canal, therapy. Second thing, we all said uncemented acetabulums. Tell me, how many times have you noticed that the incidence of periprosthetic fractures of the acetabulum is much more common in uncemented hips compared to the cemented hips? We don't come to know. We just keep hammering, we keep banging, but you don't realize superiorly there is a small crack there. So anybody disagrees with this?
I agree with you. Yeah, I agree with you.
Similarly, sir,
it is there.
If you are doing a wrong cementing, it's a surgeon's complication and not a fault of a cement.
It is, literature also says that you have got this fracture complication up to 3% or so, whereas this uncemented side is almost negligible. But again here, if somebody wants to practice uncemented hip replacement, templating is a must. Without templating, you are not supposed to go ahead with your uncemented. Templating. So I must say, if you are doing a cemented properly, you can get away with it, but cemented need to be templated properly, and you need to have sufficient experience. Then only you will be safe with uncemented.
And just to come back to the heterotropic ossification, again, randomized controlled trials, cemented, uncemented, there is no difference in the incidence of deep vein thrombosis or pulmonary embolism or the heterotropic ossification in cemented hip replacement versus the uncemented hip replacement. Correct. Now, coming to the other thing, survival issues. So if you see, there is actually no doubt, I can't show you all the papers, but I've got all the papers with me. Age more than 65 years. Cemented stems, cemented total hip replacements have not shown to be inferior than uncemented hip replacements. Thinking about the cost issue, it is 2 times or at least 1.5 times more expensive to do an uncemented hip replacement compared to the cemented hip replacements. So cost is one of the factors. I favor the cemented, and second is more than 65 years of age. Give me one reason to put uncemented hip replacement.
Yeah, here from the cost point of view, I agree with you that the cost of the manufacturing costs are more for uncemented implants, but at the same time, this gets compensated to some extent because in the case of cemented hip, you have to use cement gun, and other things. So that will add to the cost of uncemented. Even though the uncemented implants are cheaper, this cost is going to get added to that. And there has been a study to show, in America they have found, it costs $300 more in an American setting, uncemented, in comparison with cemented, $300. In our setting, probably it may be even less, I must say. So I do agree that uncemented are a bit costlier. There are some drawbacks, I do agree. The most important three drawbacks, I will agree myself. One is perioperative fracture producing possibility in the case of uncemented. Cemented has such complication rate is very low. Cost factor is one. Third is, I will admit myself, thigh pain. In case of well done cemented technique, the patient will be very comfortable, there won't be thigh pain. In the case of uncemented, your technique is not good, if the design and process you have selected is not appropriate, then patient can have some amount of thigh pain. And again, it has been found that it is to the extent of 3 to 4%, which is not going to be that disabling for the patient. So these are some of the drawbacks. Any technique, as I in the beginning itself said, nothing 100% foolproof. You have positive sides, negative sides, and you have to choose the patient appropriately. Coming to the age itself, more than the chronological age, I think it is the biological age that is more important.
Now I'd like to quote the results from National Joint Registry of England and Wales, Swedish Joint Registry, Norwegian Joint Registry, and they've all shown that the early failures of uncemented hips in first 5 to 8 years is higher compared to the cemented hip replacements because of fractures and dislocation, whereas in cemented hip replacement, the early failure is purely due to dislocation. Age, again a paper by Pitt only in 2011, he has shown that age of 55 years or more in rheumatoid patients only, the results are same, cemented versus uncemented hip replacement. So two things, if you see the early failures of uncemented hip replacements are much more compared to the cemented hip replacements. When I say early, it is 5 to 8 years. And this has been shown in Swedish, Norwegian, European, and in England, National Joint Registry for England and Wales.
I think here we have to differentiate between...
Especially 90 days rate of femoral loosening.
If you permit me, I want to add one point here. So when we are talking about the failures, you have to have two types of failures. One, failures because of the implant design and make itself. The other ones are technical. Suppose if you are not properly trained, either with cemented or uncemented, failure rates is going to be more. So, most important, we should be talking in a debate about the design faults or implant related ones, not the technique related. And at the same time, I must agree to submit myself that the technique also should not be very laborious and complex for inserting a particular type of implant. So, you have to differentiate between these two. If somebody who is not well trained is trying to do either cemented or uncemented, naturally the complication rates will be more. So you need to have a reasonable amount of training before you attempt any procedure.
I fully agree with you, sir. But I thought we are starting the debate with the fact that everyone training issues are not there. We are just going to all of us are brilliant surgeons or moderately good surgeons. And it's a question. This gentleman asks me, I've got a patient, should I do a cemented or uncemented hip replacements? Obviously, it is your preference, your training, but at the same time, what literature has to say. So, I will just conclude by saying that, yes, the trend for uncemented hip replacements has gone higher in all those countries where cemented hip replacements were far, far ahead, and the trend has gone very high, especially in the North American trial, if you see, it has gone high. Cemented hip replacements still contribute significantly. I would say I've got a number at least 43% in England and Wales, whereas 33, sorry, and uncemented has gone up to 43%. So yes, in younger, higher demand patients, uncemented hip replacement would stand better, but in 55 years rheumatoid or more than 65 years, cemented hip replacements can produce brilliant results. You can weight bear immediately, bone quality is poor, and the cost effectiveness is there. And if you have a good cementing technique, follow third generation cementing, follow the cement drainage principles, the risks of embolic phenomenon, DVT, critical bone cement implantation syndrome is also less.
So now can we start with the interactive part of the debate? So, any comments from both the speakers about hybrid?
Hybrid.
Hybrid, yes. Yeah, actually, as in the beginning itself, I said on the femoral side, both of them are equally good. That's why you can go for hybrid also. Hybrid also. On the acetabular side, it is uncemented. On the many times I do that one. On the femoral side, a cemented stem. It should give excellent results.
So I will just,
As he said already, cementing technique must be done. Third generation cementing, and everything should be perfect. Definitely, you can achieve the same results as you are uncemented. And as I said, the chance of fracture, producing a fracture are less, and thigh pain also is eliminated. So I am for it, hybrid.
and to just give you the figures, only 20% of the hips in Europe are hybrid hips, and the cumulative percentage of revision with 95% confidence interval for cemented hybrid was 2.71%, whereas for uncemented was 6.71 and 3.42 for hybrid. So hybrids still have a higher revision rate compared to the cemented tests.
So the trends now, the various trends, registries are showing that slowly uncemented side is picking up, and a significant number of hybrids are also being done. So I think definitely all of them have a place. You have to choose for the given situation.
All of them have a place. Training, personal philosophy, implant design, what you're happy with.
Excellent debate. Complete. There are three things. One by comment, one opinion, and one question. The comment is, whenever you go for the uncemented, I'm always afraid. I have the backup of cemented always.
Absolutely.
Yeah,
That is one thing.
I agree with you.
That's right. The opinion is, I may be harsh, for the industry, there is nothing to play with the cemented except the highly cross poly and vitamin E poly, they cannot do anything else. But when we use the uncemented, are we not guided by the type of
Pairing services?
That is my second, that is my comment. And the third is, my question is, I will ask.
I am a hardcore uncementer. I do not like to cement my hips. You will see
Dr.
that
Ahmad,
also.
Dr. Ahmad,
I always have a backup as Sir said.
Dr. Ahmad, my question is, when there is the age of 55, 45, why the age is about 45? Why not 30? You tell me, how is it inferior if you're doing 30? You admit yourself.
So they are all short-term results. I fully agree with you. But the definitive results in more than 65, they are equal. Less than 65, they are not equal. Uncemented has shown superior in the first 10-year results. Long-term studies will come as we come to know. 55 years, only in rheumatoid patients, cemented have shown an excellent result. Now, Sir also pointed out that the cemented hip replacements are better for patients with avascular necrosis, Paget's, and a single stent. So if you see the avascular necrosis, if you get an MRI of these patients, you will see the AV and edema going not only up to the proximal femur, but also going down a little bit on the diaphysis also. So if you are using a proximally coated stem, or if you are using just a stem with the principle of proximal coating, it is not going to hold there. Either you use a fully coated distal, fully coated stem like a corail, proximal coated stem like an ML taper or a striker one, they are not recommended. Or a cemented stem which can give you a fantastic fit throughout, and no reason why the bone ingrowth will not take place. Because AVN has a diseased bone. So I would be really worried. Will the bone on growth or ingrowth take place on my uncemented stem? Especially if the coating is only in the top part.
But AVN is confined to the head part only, not in the stem. So there is no necrosis bone there. In fact, there will be hypervascular.
There is edema there.
So uncemented should go.
In AVN,
Yes.
we are using in AVN proximally coated throughout my 15 years. They are working very well.
That's what I'm also saying the same.
Any proximally coated from any company,
Metaphysics,
it is confined to the head. It is not necessary to use fully coated at all.
No, I didn't say that one.
No, we were debating, sir.
The pathology is confined only to the head, not the metaphysics or diaphysics. They are in fact hypervascularity is there. So bone ingrowth will be better. Only thing is in AVN, I don't know, I am sure it is anybody's experience. AVN, starting from skin incision, the bleeding will be more, ooze will be more, because of reactive hypervascularity. In contrast to other diseases like osteoarthritis, rheumatoids, AVN is special. So you need to have sufficient amount of blood when you are going for total hip replacement in case of avascular necrosis. Starting from soft tissue down to the bone, there will be bleeding.
This is the last question because we have to move in the further program.
Question to Dr. Reddy. You are promoting uncemented or hybrid. My question is, suppose you are doing an uncemented THR, at what you see in the acetabulum that you want to switch over to cemented? You see the Cawnpore cancellous bone is not there around the periphery, the quality of bone is not good, you could not do proper rimming. What are the most important key indications switch over to cemented?
Yeah, in case of uncemented hip, yes. See, I will be looking for a hemispherical, after reaming, I need to have a hemispherical shape. The cup need to be, a trial cup need to bottom out. The contact, as we know, for uncemented to be successful, a minimum of about 60% good contact should be there. This is primary. So, many a times there will be remodeling of the cup, and when you go on reaming, our aim is to say it will be something like an oblong hole, acetabulum. You have to get into the hemispherical. So that is the idea of going for reaming. Until I get a hemispherical, I need not have contact at the dome, but I need to have a good peripheral contact. That's what I will be looking. I will be reaming until I get that hemispherical shape. Then I will look about the bleeding. Whether this hemispherical bed I have created is bleeding or not. As I already said, we don't need to expose the cancers. In fact, we are not supposed to expose. Keep the cortical only, but many a times it is aberrated bone. In which case, don't ream further, but use curettes. Use curettes to scrape out all that aberrated bone and get some bleeding. That's what it should be. Don't go on reaming and enlarging. You might compromise the walls, anterior wall and posterior wall, in the process of trying to get some bleeding bone. So ream appropriately. Once you have reamed, you think you have reamed to the right size and right dimensions, then look for the bleeding. We need viable bone. If it is aberrated bone will not grow. In which case, go on scraping with a curette until you get some amount of bleeding. So once you reach that stage, I think you are ready for uncemented. If you don't get even that, then also, and you are going to compromise the walls, anterior and posterior wall, because there is no scope for further reaming, probably you have to switch over to, yes.
Very important point where acetabulum is sclerotic. Like you do in non-Indians, use a curved sharp osteotome and put osteotome all over the sclerotic part. That helps a lot. Basically, you have to do injury to the bone, then osteoplastic activity is stimulated. So like non-Indian, do multiple curved osteotome all around the acetabulum where there is a sclerosis. That is very which I practice.
Around the periphery, the quality of bone is not good, you could not do proper rimming. What are the most important key indications switch over to cemented?
Yeah, in case of uncemented hip, yes. See, I will be looking for a hemispherical, after reaming, I need to have a hemispherical shape. The cup need to be, a trial cup need to bottom out. The contact, as we know, for uncemented to be successful, a minimum of about 60% good contact should be there. This is primary. So many a times there will be remodeling of the cup, and when you go on reaming, our aim is to say it will be something like an oblong hole, acetabulum. You have to get into the hemispherical. So that is the idea of going for reaming. Until I get a hemispherical, I need not have contact at the dome, but I need to have a good peripheral contact. That's what I will be looking. I will be reaming until I get that hemispherical shape. Then I will look about the bleeding. Whether this hemispherical bed I have created is bleeding or not. As I already said, we don't need to expose the cancers. In fact, we are not supposed to expose. Keep the cortical only, but many a times it is aberrated bone. In which case, don't ream further, but use curettes. Use curettes to scrape out all that aberrated bone and get some bleeding. That's what it should be. Don't go on reaming and enlarging. You might compromise the walls, anterior wall and posterior wall, in the process of trying to get some bleeding bone. So ream appropriately. Once you have reamed, you think you have reamed to the right size and right dimensions, then look for the bleeding. We need viable bone. If it is aberrated bone will not grow. In which case, go on scraping with a curette until you get some amount of bleeding. So once you reach that stage, I think it is you are ready for uncemented. If you don't get even that, then also, and you are going to compromise the walls, anterior and posterior wall, because there is no scope for further reaming, probably you have to switch over to yes.
Very important point where acetabulum is sclerotic. Like you do in non-Indians, use a curved sharp osteotomy and the put osteotomy all over the sclerotic part. That helps a lot. Basically, you have to do injury to the bone, then osteoplastic activity is stimulated. So, like non-Indian, do multiple curved osteotomy all around the acetabulum where there is a sclerosis. That is very which I practice.
Because Dr. N. Somashekhar Reddy has to start the first surgery. Before that, he has to deliver his talk on anterolateral approach. The spinal is already being applied to the patient in the OT, so Dr. Somashekhar Reddy has to leave. So he is starting with the talk.
Which condition you are operating for and what for you are operating, there are so many approaches. And for orthopedic, there are now anterior approach, anterolateral approach, posterior approaches are there. And one should be well acquainted with different approaches. One should not be sticking to one approach, even though person may have a personal preference to one or the other one. They should be well acquainted with the other approaches also.